Welcome to the Masterclass of Critical Care Medicine from Yashoda Hospitals and IDCCM Hyderabad. Today's topic for discussion is acute pancreatitis. We have very senior most examiner, Dr. Manimala Rao Madam. She is Director and Dean of Education from KIMS Hospital. And another senior examiner is Dr. Harish. He is Academic Incharge and Senior Intensivist from Narayana, Hrudayalaya, Bengaluru. Case will be presented by our DrNB students from Yashoda Hospitals, Secunderabad, Dr. Uday and Dr. Vignesh. Both will be presenting the case. Dr. Uday, you can start the case.
Good evening, good evening, sir.
Good evening.
This is a case of a 25-year-old male farmer presented to the ER with complaints of diffuse abdominal pain since 3 days and a fever since 2 days and a shortness of breath since 1 day, which is gradually in onset, and a decrease in appetite since 3 days. And coming to the history of a present illness, and the patient was apparently asymptomatic 3 days back, and then suddenly developed diffuse pain abdomen since 3 days. Pain is present more on epigastrium region, no aggravating factors, and relieved by sitting up from recumbent position. Pain is associated with fever since 2 days and associated with mild minimal abdominal distension. And no history of association with vomitings or melena, heartburn, diarrhea, and change in bowel and bladder habits. Coming to the shortness of breath, it is in duration since 1 day, gradually in onset, and not associated with paroxysmal nocturnal dyspnea or orthopnea, and not associated with cough or sputum, and no aggravating or relieving factors. Coming to past history, no similar complaints in the past, and no history of hypertension, diabetes, tuberculosis or asthma, and no history of previous abdominal surgeries, and no past drug history. Coming to personal history, appetite decreased, bowel and bladder habits are regular, and sleep disturbed, and history of alcohol intake since 3 years. Coming to the general examination, 25-year-old male patient, conscious, coherent, cooperative, moderately built and
I'm listening. Okay. Can you see me? Sorry. Go ahead.
Good evening, madam. Dr. Harish here.
Good evening.
Good evening. How are you?
Fine, madam.
Good evening, ma'am. Coming to the general examination, 25-year-old male patient, conscious, coherent, cooperative, and moderately built and nourished, and no signs of pallor, cyanosis, clubbing, and icterus, lymphadenopathy, and perineal edema. And initial temperature was 101 degree Fahrenheit, and heart rate was 1 beats per minute, and initial BP was 110/70 mmHg, and the initial respiratory rate was 35 breaths per minute. On room air, initial SpO2 was 85%, with 6 liters of oxygen support, 94%. Coming to GCS was 15/15, and pain score was 8/10 according to visual analog score. Coming to systemic examination, GID upon inspection, abdomen is distended, no visible organomegaly, no scar sinuses or dilated veins, no visible peristalsis, and hernial sites were normal. On palpation, abdomen is distended, diffuse guarding and tenderness present, and no organomegaly and no fluid thread. And coming to percussion, tympanic note is note all over abdomen, and auscultation sluggish bowel sounds, no peristaltic movements. And coming to the other system examination, patient is tachypneic with 35 breaths per minute. On room air, 85% of SpO2 with 6 liters of oxygen support, he is 94%. Normal vesicular breath sounds are heard, no wheeze or added sounds. In CVS, S1S2 heard, and no murmurs and no palpable threads. Vignesh.
Yes, sir.
Dr. Uday, just
Yes, sir.
on the basis of your clinical history, okay, you have taken the history like a typical medicine candidate, general medicine candidate kind of this one. So I just want to understand, like when you tell cyanosis clubbing, how you are going to correlate with your patient's history. So what you expect, okay, in terms of cyanosis, how means which category of the patient can have cyanosis, clubbing, pallor, and all those things when they came with some signs and symptoms in and around tummy, abdomen. See, you have written everything nicely in a routine way, no? How you are going to correlate each and everything in your history, examination, and all.
Patient actually presented with abdominal pain since 3 days, sir, which is more region, relieved with on sitting a position, patient pain is relieved, and there is no previous complaints or previous history of abdominal pain, and no history of no drug history. And
why you want to take a drug history in a patient with a pain abdomen?
Some of the drugs may induce gastritis, NSAIDs, prolonged use of NSAIDs may induce gastritis. That's why I took history of drug history.
So you have mentioned loss of appetite was there.
Yes,
is there any significance for that in a young gentleman who is 25 years in terms of his clinical manifestation? Why you want a history which is having a loss of appetite, and you are okay with just loss of appetite, yes or no, or you want to have anything along with that?
Decreased oral intake, it is associated with pain abdomen. Patient having pain abdomen, this is associated with the decreased oral intake.
So,
decreased with appetite present.
What are the thoughts which you will get when you say decreased appetite, pain abdomen? So what are the things which come to your mind? That is what the doctor is asking. What are the DD which comes with this 2 or 3 things which you have said?
Patient
pain abdomen, decreased appetite, no vomiting, right?
Yes,
maybe little nausea, but no vomiting as such. So what are the main things which will come into your mind with those 2 things? Young fellow.
Appendicitis can be a differential diagnosis. Other possibility is GRD.
Upper abdominal pain. So in the beginning, in the beginning it can be there.
Gastritis.
Gastritis. Right?
Gastritis, ma'am.
Yeah.
Gastritis and gastroenteritis and
no, there is no vomiting and diarrhea.
Acute pancreatitis. Acute pancreatitis. And
gastritis. Maybe you will think if there is any, abdomen is little tender.
Upper abdominal pain,
and loss of appetite. Okay, these are the 3 main things which you are seeing in that. So you can have all these things. Gastritis could be a pain abdomen due to any small perforation which can close. All these things could be typhoid, can perforate and give rise to. So you have to get all these things and then take away each one as other things come. That is what is the way you take the history and things. Okay, go ahead. Doctor, you were asking something.
No, with the loss of appetite, you want an add-on history when you ask about the loss of appetite, or you are okay with the loss of appetite? Even though patient is an young, so nowadays we don't have any differentiation for malignancy. Okay, so one thing we have to very specific on the loss of appetite, its duration. So it is, see, one day I had some sort of like abdominal discomfort. So it may be a one-day loss of appetite. It doesn't mean anything significant in terms of our further evaluation. So we need a duration of loss of appetite along with that of the weight loss history is very, very important. Because see, even ethanol abuse itself can lead to some sort of subacute to chronic loss of appetite with a recurrent binge of alcohol if they are too much abused with the loss of weight also. So that we need to give some weightage here. And
so it's only 3 days, no? It's only 3 days that we said loss of appetite. Acute, more acute.
Okay.
Okay, go ahead. Doctor, are you there?
Yeah, we're not.
Uday,
He's on mute.
Yeah. Tell something more on that. Go ahead and tell something. What is other things? Where is he?
Uday,
He's there, but not able to see the slide.
Uday, unmute yourself, Uday.
Vignesh, you can answer.
Yeah. Yes, unmute.
Yes, ma'am.
Proceed, Uday.
Yes, sir. Yes. On day 1, patient had a maximum temperature was 101 degree Fahrenheit, and patient is tachycardic and tachypneic. On 5 liters oxygen, oxygen patient is maintaining a 94 to 96% of saturation with a pain score of visual analog score of 8/10. We started fentanyl SYS 20 to 30 mics bolus, and initial.
Uday, share your slides.
Yes, sir. Yes. Sir, is it visible, sir?
Yeah, please go.
On day 1, patient has a maximum temperature of 101 degree Fahrenheit, sir, and the patient had a tachypnea and tachycardia with serious symptoms. And on 5 liters of oxygen, patient is maintaining a 94 to 96%. And visual analog score was 8/10. He is requiring intermittent fentanyl boluses with 20 to 30 mics. And initial bicep score was 3. And initial ABG is showing 7.47 pH and PCO2 of 27 and PO2 of 56 with type 1 respiratory failure and bicarb of 20 with base excess of -3.6 and initial lactates were 5.14, which indicates the organ dysfunction. And we initiated according to.
Can you tell me? Excuse me. Can you tell me? Can you read that and tell me how is it? How do you talk about the ABG? Because you are at the bedside. So what is the ABG? Can you tell me?
Yes, ma'am.
Yeah.
This is a respiratory.
No, don't go like that. Don't go like that. In exam, you can't just go like that. Okay. How do you read the ABG?
With a pH of a 7.4.
Yeah, so 7.4.
7.47.
It's almost normal. Okay.
Almost normal.
Normal. Yes. Then
bicarb value of 20, ma'am.
Why are you going to bicarb? What is the next?
Next value is PCO2, ma'am. PCO2 is 27. That is it indicates.
So it looks like alkalosis.
Alkalosis,
right?
ma'am. Respiratory alkalosis.
Yeah. Then
PO2 of 56 indicates a type 1 respiratory failure, ma'am. And
56. No, doctor, whenever you tell me about ABG, because I am very clear, because these are asked in the exams and you have to tell correctly. Okay.
Yes.
So when you say PO2 of 56, what is FiO2? Because it's not written there, so I won't know. Is this FiO2 how much?
On FiO2 of 0.3, ma'am. With 5 liters of Yes, ma'am.
Is
0.3
he
to
get-
0.4.
No. 5 liters of what? How is he getting the oxygen?
5 liters with face mask, madam.
Face mask cannot be 0.3, doctor. 5 liters, at least you will get us 0.4 to 0.5. Okay. So this is what I am trying to tell all of you. Please read those things at bedside so that it is easy for you to tell it anywhere in the world. Okay. So you have to tell what is the FiO2 and what is the PO to FiO2 ratio. Now, if you say, okay, let us take 0.4 and your PO2 is only 56. So what is PO2 ratio? PO2
Near
and FiO2.
110, ma'am. 110.
110. So what is it? 110 signifies what?
110 signifies the patient had a low PF ratio, sir,
Yeah, so
indicating
that's-
the type 1 respiratory failure.
Yes. So it is a
and-
severe. It is
Yes,
severe
severe,
type 1, whatever.
Yes, ma'am.
You know, maybe going into
Into
ARDS.
maybe landing
Yeah.
into ARDS, ma'am.
So that is what you have to. And then next, what will you do?
With a
I'm
bicarb
sorry,
value
because
of
these are important for you to answer in the examination. This is very, very important. You don't answer, we don't go further. Okay. If you have a pH, if you have an ABG, you should be able to answer it thoroughly. Okay. So next, what is that? Bicarb is 20.
bicarb is
So-
20. Yes.
Yeah.
Uh,
So
with base
how do you say that it is compensated or not compensated?
is compensated, ma'am.
So how do you say?
com-
What is the formula? Okay.
Yes, sir.
Doesn't matter. I'm just saying there are only
Yes, ma'am.
6 formulae. 4 for respiratory and acidosis, alkalosis. This is acute. So you have to know what is acute. Okay, anyway, you don't know, you better read it up. Or you ask
Yes.
me little later, I'll let you know. Not for us. Okay. So some amount of compensation, it's always say partially compensated. Respiratory alkalosis with hypoxia. So that is the thing which you have to say. Okay. Okay, now go ahead. You have done the ABG. Next, what you are saying?
In ABG, initial ABG, lactates were 5.14, ma'am. 5.14 millimoles. Sir. And based upon that, patient actually admitted on the day 3, ma'am, day 3 of symptoms. Sir. We initiated fluids with 150 ml per hour initially. And initial triglycerides values are 120
So
milligrams.
if you just tell me IV fluids, I will not
Yes, ma'am.
like it. So what fluid you have given?
Yes, ma'am. We are given ringer lactate, madam.
All
Ringer
right.
lactate with 150 ml per hour.
Okay.
We are given.
Why you are giving 150 ml Uday, on day
Yeah,
3?
what is blood pressure? You didn't tell about that.
Initial blood pressure was 110/70, madam.
Okay.
No, you feel like patient is still going to be volume responsive on day 3 of his severe acute pancreatitis, means acute pancreatitis?
By
3 days, the patient didn't receive any fluids or as such. So the patient presented to us just now only. So increased lactates along with tachycardia of more than 154, not corresponding to increased temperature elevation, again tells us the patient can be severely hypovolemic. So we started with initial fluid resuscitation followed by a fluid bolus of 150 ml per hour. We started because of increased lactates, and our hemodynamic targets are not achieved as such in the start.
What targets you have in the beginning of patient assessment as an hemodynamic?
Initially, we had a target of maybe a decrease in heart rate of say 120 per minute, sir. And
You can achieve by giving, suppose if patient is started on fentanyl, as you already, so if you give a fentanyl, his heart rate is going to be decreased drastically.
And along with it, we monitor urine output also. We monitor urine output of 0.5 to 1 ml. Initial catheterization, we hardly had any urine output at that point. So we have to give fluid resuscitation.
Some arbitrary clinical endpoints you are setting for assessing the adequacy of the resuscitation. So what is BICAP? You written BICAP 3.
bedside score for acute pancreatitis, sir. It has 5 parameters: blood urine nitrogen value more than 25, and impaired mental status, and
Age more than 60 and pleural effusion.
pleural effusion, and
what is the significance cutoff value for bicep score? What is its sensitivity and specificity?
And value of more than 3 indicates a severe acute pancreatitis, sir. When compared to other scores, it can be used during admission. Other scores requires 2 readings at the time of admission and at 48 hours.
What other scores?
Ransom score and Glasgow Emery scores.
Basically, that is a disadvantage. You need to wait for 48 hours to complete the score of 0 and 48 hours of Ransom, and Glasgow and Emery score is at 48 hours. So the bicep is having a good sensitivity in terms of picking the severity of the pancreatitis. So if it is more than 3, mortality is around 30-35%. Okay, so your assessment should be, see, basically this young gentleman, we are not suspecting any sort of any associated comorbid condition. So you can still take a challenge and fluid resuscitation than going for the fluid challenge, because obviously you have clear on that not received any of the volume till now. And along with that is markers like lactate, tachycardia, tachypnea. So all these things suggest you towards the top of volume depletion. And you have any other parameters to suggest is still volume depleted?
Hemocrit is actually on the higher side.
Hematocrit. Okay, so still hematocrit is also bit high.
Hematocrit.
Are you aware of any fluid studies in pancreatitis? See, now you mentioned already bicep on the paper. So you are preoccupied. Okay, you have received any patient with the background of see, I just want to dig into differential diagnosis, but you already on day 1, so you made the diagnosis like on the basis of the clinical examination. So how you are going to diagnose the acute pancreatitis based on clinical?
There are 3 parameters, sir. And acute abdominal pain, upper epigastric pain, which is relieved on sitting position, and amylase and rise in amylase lipase values of more than 3 times of upper limit of normal, and imaging to support acute pancreatitis, sir.
All the 3 component?
Sir?
All the 3 criteria you want?
No, sir. 2 of them will be sufficient to label it as an acute pancreatitis.
Tell me something about the fluid volume which you decided. Okay, so how you want to give 150 ml? Why not like 300 ml? And are you aware of any of the data suggesting this?
Initially, sir, initial fluid resuscitation on day 1. Usually, pancreatitis patients requires fluid resuscitation for 24 to 48 hours, sir. Initial fluid resuscitation 20 ml per kg, initial hours, 1 to 2 hours. Then we have to check the blood urea nitrogen and decrease in hematocrit values, whether patient is responding or not. Then if he is responding, then we have to come down on fluids to 1.5 ml per kg. If he is not responding, we have to again give bolus of 20 ml per kg. Then we have to reassess every 6 hourly by parameters by blood urea nitrogen or hematocrit and dynamic parameters, and then we have to give fluids. If he is responding after second bolus, then we have to come down on fluids to 1.5 ml per kg. If he is not responding, we have to.
My question is, why not 250 ml, 300 ml and all? Are you aware of any of the comparison of study? Like yes, maybe what happened if you give too much of high volume in a pancreatitis patient? Any data to suggest that, evidence to suggest that?
Yes, sir. There is a comparative study between 3 to 5 ml per kg compared with 10 ml per kg. But with 10 ml per kg, there is a lactate clearance was achieved early, but there is a high chance of patients are going into intra-abdominal hypertension, sir.
There was one fantastic study. They compared a very high volume versus that of the required volume, somewhere around 3 to 5 ml. Clearly, it suggests even though you achieve the lact time early, that is the lactate clearance, but they landed up with a very bad abdominal compartment syndrome. Okay, so go ahead. Means like how you want to further proceed with this patient in terms of respiratory support, in terms of
What are other what are the other investigations you have done besides these? where is the lipase and amylase have been noted here? These are the ones, the last ones.
It's down, ma'am.
Yeah.
Amylase is
Is there any other investigation can you do to diagnose or
Can
potentially?
you do anything at bedside? Can you do it?
Ultrasound abdomen is generally done to
Yeah, then
look for the
why-
cause of pancreatitis. It's to rule out a gallstone-related pancreatitis.
You can see now the whole abdomen. How much
Yes,
is there any fluid? Is there any
Yes, ma'am.
fluid in that? Is there any other thing? You can easily make out, right?
Yes, ma'am.
That is one of the important things before you can even all these things come. If any pain abdomen, you can do. It's all there with us. There is no problem in doing an ultrasound. And most of you are trained in that, isn't it?
Yes.
Are you aware of the amylase lipase limitations? And is there any way can we do amylase lipase from any other source for potentiating the diagnosis? Lots of things happening in and around these areas.
If there is any abdominal fluid collection, we can take the fluid, and that has been tried, but not recommended as such.
More than that, they have a good data on that, but with again the problem with the sensitivity and specificity.
Urinary,
Urinary trypsinogen and
trypsinogen.
urinary amylase. Okay, because amylase is having a limitation in terms of its specificity. So, what are the other causes for rise in amylase?
Perforation and mesenteric ischemia and bowel obstructions.
Even salivary amylase also.
Salivary amylase.
Which is having a long half-life, amylase or lipase?
Lipase. Lipase.
Lipase is having a longer half-life. So there are lots of data coming up with the urinary trypsinogen and urinary amylase. Even one Indian data, urinary pro-amylase from Hinduja Hospital got published maybe 5-6 years back only. It shows some clue regarding the diagnostic ability of the urinary pro-amylase and isoamylase with a different cutoff, but we need a standard validation and standardized cutoff value for all those things. Okay, so this patient is having a PF ratio of somewhere around 100, so he's fitting into definitely type 1 respiratory failure with a categorization of severe ARDS criteria almost. Okay, so how you want to support this patient? Are you happy with the oxygen? You just proceed with your further line of planning.
Yeah, you tell us what day 1, day 2, whatever. What did you do further?
Actually, this oxygen was on room air, madam. Actually, the ABG was taken on room air. So
This one, the first one.
Yeah,
Okay.
it was on room air. So the patient was saturating somewhere around 94%, 95% on 5 liters of oxygen. Next.
No, that's okay. You have given oxygen. What is the thing you really will see once you give? Is it only saturation?
No, the tachypnea comes down with.
So that is what I'm saying. What was he still tachypneic? Because everywhere you have written 35. Has it come down? And if the tachypnea is so high, then what is your methodology to take care of him? With the pancreatitis, with fluid inside, what is the method?
So even if the patient continues to be tachypneic on even on starting oxygen, then we will give a trial of NIV, keeping into consideration that aerophagia is a possibility. We have to keep that into consideration, and we can give a trial of NIV.
Are you happy with NIV in a pancreatitis with the abdominal which is tense? Intra-abdominal pressure is high.
Why not high flow? Why not high flow nasal cannula? Why you are choosing the NIV? Are you want to consider support for his workup breathing? Is hypoxia? What is your goal when you start NIV in a patient who is badly hypoxic?
To support work of breathing.
Yeah. So you have to tell me whether his work of breathing has come down with oxygen. That is what I want. Okay.
Yes,
suppose if you have put your, you have given, and then you have found that the respiratory rate has settled and the saturation has come up, then I will watch him for some time. But only the saturation has gone up, but the respiratory rate is still high. Patient is panting like that and still is, then within an hour you have to take another EBG. See what it is. As the PCO2, what happened? Is it still going down? Is the PO2 is still low? Then you have to take test, right? And what is the other thing which makes you take a decision? besides the work of breathing?
Tachycardia settles if, due to distress.
Tachycardia can come with pain and fever, right? And with a little hypoxia. But here it's got quite a bit of hypoxia. So usually it goes to the other side. These are basic physiology. I only talk about little basic physiology. If you remember that, then we can do everything in a nice way.
If
Suppose if you have taken another EBG after about an hour or an hour and a half, you have tried all that. And or if it has come down, as doctor suggested, we can just see if it has come down, tachypnea as well as your saturation gone up, tachypnea come down, then maybe you can try on high flow for some time so that you will get. Then again, you have to see how is he doing. Or if he's quite okay even on that mask and is not tachypneic, then we can watch. There's no problem. But if the tachypnea is still like that, then we have to take a test. See how the lungs are. Okay, you will at least,
yes,
you see the lungs, no? How they are.
yes.
So what will make you feel that I think I have to do something more for the patient?
Look about
What is the commonest organ gets involved in pancreatitis? If you are looking at it that way.
Lungs, pleural effusion will tend to happen,
that is
or the
what-
patient can land up in ARDS
Pleural
as well.
effusion, or it can go to ARDS a little later in another 3 days.
Yeah.
Already 3 days history is there. Okay. So these are the things which have to come, all of them together. They can't come every organ. The other one is, of course, your kidney. Because you said you have given fluid. As the amount of urinary flow improved after that?
Yes, ma'am.
Yeah. Yes?
Yes, ma'am.
Yeah. So that means you are able to get over. So let us now go to the next one. These are the times where you have to see all these 3 things together. When you think pancreatitis, when he is having fever, he is having tachypnea, he is having low oxygenation. So all these things have to be continuously seen together, not in a separate entities. Okay. Then
When was the CT done?
It was done in the ER and it has been shifted to our ICU actually at the time of admission itself.
With a contrast?
Yes.
Yes, sir.
When you want to, suppose this patient was not done with the CT. So in which scenario you want to consider CT with a clinical suspicion of pancreatitis?
CT generally we do after 72 hours, provided there is no any clinical improvement is there, then we may go ahead and do a CT. Or if there is any other clinical suspicion of pancreatitis on the lower side, then again we may do a CT. Or to rule out any other diagnosis, as in any intestinal perforation is strongly suspected, or ischemia is suspected rather than a pancreatitis, again we can go ahead and do a CCT abdomen in the initial part.
So are on a routine basis after 72 hours, even though your diagnosis is confirmed, you need a CT in pancreatitis patient?
The patient is not improving.
No, if he is like holding on, still you want a CT?
No, sir.
So what are the disadvantages of being why it is discouraged not to do CT in early days of pancreatitis?
Pancreatitis features abdominal collections and changes of pancreas changes will take some time to develop, sir. That's why CT abdomen is delayed, and also contrast related injury during the initial resuscitation phase is a challenge, sir.
So basically patient is still under the resuscitation, not adequately resuscitated. On that, if you give a contrast, it is going to worsen the renal dysfunction, shifting the patient, and it is going to again mismatch your on the go of resuscitation and all. Mainly demarcation is the problem. So along with that, there are lots of data. See, contrast, even though we use isoosmolar contrast, that will add to some sort of viscosity in the blood flow, which may hamper the microcirculation of even pancreas also. There are some theoretical rationality, so that again may worsen the necrotic involvement of the pancreas and all. So you started this patient on fentanyl. Suppose it is not going to work out. So is there any other options to reduce this pain?
epidural anesthesia can be tried, and patient control analgesia with can also be
Can
tried.
we use morphine for this patient?
Can be tried, sir. Morphine can be tried.
Is there any problem with the morphine?
There is a theoretical concern regarding the
Sphincter dysfunction is there.
sphincter dysfunction, but
it is not being shown.
there is no evidence to support that.
So it is a multimodal modality. If patient is not settled with one opioid, so you can take a Kalan using the epidural. Morphine is okay, no contraindication. Okay, so that's the thing.
Has
What
anybody tried tramadol? IV infusion? There is a nice paper we have written. So continuous, very small dose with a little bit of this thing. It very really helps the patients. It doesn't cause any other problem which you have seen, but you have to give it as a continuous infusion in a small dose. Because we have tried in number of pancreatitis people, and then we found it easy, and we have also written that up. Okay. I mean, I'm just saying that it's not 100% evidence, but this is also another method we can easily do from the very beginning. It does not cause any respiratory depression, and you can add a little palonosetron, just 0.3 milligram for that, and give a very small dose. After that, you give fentanyl in the beginning, but you can continue with this, and they get a tremendous amount of pain. This is my own. We have written the paper. That's why I'm saying. If I have not written the paper, I wouldn't even talk about it. Okay. Anyway, besides that, because you can see various things you can try. Putting an epidural in these patients who are very painful is also difficult in that sort of a setting, but we have tried. But after we have done this, we really did not require very much of it. So, but you should know how to give it. Unless you read a paper, don't try on your own methodology. So this is one thing which you can help the patients, because the pain is the most important thing, which is going to really cause a lot of problems for this pancreatitis patient. So the first thing is to relieve pain. And if you are relieving pain, it has to be continuous rather than intermittent. That has to be understood very thoroughly by each and everyone who treats pancreatitis. Okay. What is the next one? CT. Anyway, ultrasound. Did you do ultrasound for this patient?
Yes, ma'am. Ultrasound was done, but it didn't show any.
It did not show anything.
No, ma'am.
Was there any fluid? Was there any collection?
It was not shown in this thing. No,
Okay.
ma'am.
Okay. Was there any stone? Nothing?
No, ma'am. No, ma'am.
No. Then okay. So what happened later? He's still having day 2 to day 4. He's having tachycardia, tachypnea on 6 liters of oxygen per minute. Then
there was a persistent fever spikes there, ma'am, and there is abdominal distension, but he was good to take on orals. Actually, he is passing urine adequately with loose, and stool has been also passed on routine basis. And look at the pain score; it was 4 on 10. He was on fentanyl patch along with as required fentanyl SOS. His hemoglobin and TLC counts were within normal limits. And we decreased the IV fluid intake based on his requirement to 60 ml per hour as of now. And since persistent fever spikes, we have sent for cultures, but peripheral smear doesn't show any band forms or cytoplasmic vacuoles. The ABG had shown decrease in lactate clearance has been noted in the ABG as well. So we are good until day 2 or 3.
Why you send culture on day 2 to 4 in a pancreatitis patient?
To rule out any other infection which is not being identified, which is causing fever.
Means you are suspecting an infection origin fever at this level?
It shouldn't be least likely, but just to rule out.
You started him on antibiotic at this level when you taken the culture. If you are preoccupied with, okay, is having an infection origin for the fever?
No, sir.
so did you start an antibiotic?
No, ma'am.
No.
No. Only pain relief, fluids, no
Yes, ma'am.
antibiotic.
No, ma'am.
Okay.
This young gentleman with a background of ethanol, so with a pain abdomen, bit of loss of appetite, so came with tachypnea, tachycardia, so we have controlled the pain, given a volume resuscitation. So started him on nutrition. So fever was the issue. So how you want to further proceed now onwards? So what may be the etiology? You feel like it is the ethanol is the etiology for this patient?
Yes, sir. We don't have any other etiology, at least until this point. So,
What are the other causes of pancreatitis?
gallstone we have ruled out,
Mm-hmm.
and triglyceride as well we have written at the time of admission, which is normal.
Mm-hmm.
And drug history, there is no drug history as well.
What are the drugs which will cause pancreatitis?
Hydrochlorothiazide and nucleoside reverse transcriptase inhibitors and
Sulfonamides, Lasix, azathioprine, 6-mercaptopurine.
Lasix will cause or thyroid diuretics?
Diuretics.
Mainly thyroid diuretics.
Hydrochlorothiazide.
Yeah. So then, just mention what other causes. Okay, drugs, pentamidine, dapsone, okay, even trimethoprim can also, means Septran also can cause, azathioprine can cause, valproate can cause. What other causes for pancreatitis?
autoimmune, maybe the causer, IgG4 mediated.
Okay.
And familial in case of
Very low probability. So see, my question is, why all the ethanolics will not develop pancreatitis? Is there any relationship with the genetics for pancreatitis in and around those who consume ethanol?
there is a
Only 10%.
SPINK1 gene is associated with ethanol-induced pancreatitis in these patients. And
what is SPINK1?
SPINK1.
Actually, what happens in pancreatitis? What happens actually? What happens to the enzymes?
The pathophysiology of pancreatitis is acinar cell destruction and
that is pathology.
Yes.
What happens normally? What happens to the enzymes?
Enzymes were elevated, man, and
No, doctor. Enzymes are elevated. Normally, what will the enzymes? Where do they go? They are not active in the pancreas. They are only active once they go into the gut. But in pancreatitis, they are active in the pancreas and destroy it. That is the thing. They do something like an autolysis in the pancreas.
Auto digestion of the pancreas.
That is what.
So lots of theories, common channel theory, obstruction theory, reflux theory. These are proposed to explain all these things, but it is mainly auto digestion.
Nobody knows exactly what happens.
Yeah. So other causes are like hypertriglyceridemia, trauma can cause. So pancreatitis secondary to ERCP. So around 5 to 8% post ERCP there is a pancreatitis. Worm ball ascariasis. Okay. So all these worm balls can echinococosis means worm balls inside the abdomen can cause severe acute pancreatitis and all. So these are the other causes. So further, how you are going to proceed? So you started him on nutrition. Suppose this patient is not tolerating your oral initiation of the feed. How do you want to troubleshoot a patient with a pancreatitis who is not tolerating oral feed?
We can try enteral feeding, sir, with a nasogastric tube. If he is not tolerating nasogastric tubes, post-pylorus.
What nasogastric tube?
Enteral feeding with a nasogastric tube, madam.
Is the Ryle's tube?
Yes, Ryle's tube feeding.
Where is Ryle's tube going to be? Where is the pancreas coming? So that is what I'm saying. If it is not tolerating, are there any other types of tubes? You can put it across the duodenum. That's what you have to tell me. Because if he is not tolerating any enteral feeds, again putting in the stomach, is it correct?
Yes.
I mean, just think about it. Logically think. Okay, if you answer in the exam also, or logically think also. Because if you are not tolerating, he is just spitting out whatever you are giving. And if you are giving any feed, it is worsening the distension. Then what is that you can do? You still want to be, then you have to do a little, put it into the jejunum. There are tubes which are there, right? So that can be thought of, one. Okay.
How you want to initiate the feed?
As soon as possible, we have to start interval feeding, sir.
How much
And,
calorie, protein, what formula? See, you have to advise to bedside nurse what to indent, what is your calculation and all. So how you are going to tell?
As acute pancreatitis is a catabolic state, it requires more calories, nearly 25 to 30 kilocalories per
So in
kg
a catabolic state,
per
you
day.
need a hypercaloric feed in a catabolic state?
No, sir.
And
We start slowly actually. We start if it's a case
The
of
question
pancreatitis
is,
having
in a
abdominal.
catabolic phase, the worry is your protein breakdown.
protein one, yes.
Not a calorie, you need to go up and you have to give a more and more of calorie kind of this one.
Yes.
Yeah. So how much calorie, how much protein you require in the same gentleman who is not tolerating nasogastric means enteral feed. So you put nasojejunal post pyloric and you have to start the feeding.
20 to 25 kilocalories and protein accounting to 1 to 1.5 gram per kg to start with.
What formula you give? So
We
I mean different types of enteral feed. Which one you are going to choose?
will start with
Polymeric feeds.
polymeric feeds.
What is the difference between polymeric and other types of feeds?
In polymeric, we have all as intact carbohydrates, intact fats, and intact proteins as well. When we go to semi-elemental or polymeric feeds, then there will be into oligosaccharides and MCT based.
So it is a semi-digested and semi-eliminated. Means it is going to be in the peptide formula. Okay, so nowhere we have a apparent guidelines to start with a semi-elemental. Always it's a polymeric. If they are not tolerating polymeric feed with the intact protein, carbohydrate, and the whole of the fat, so then you can take a call on going for semi-elemental, that is the peptide based. So you require fat-free meal, fat-free diet always in the pancreatitis? Apparently no. Okay, so always it is the regular way of feeding. If they really not tolerate, so then how much volume you want to start?
Initially, we'll start with 15 to 20 ml initially, sir. If he is tolerating, we can increase the feeds.
How frequently you are going to tell your sister, okay, once in 6 hours you increase, once in 4 hours, or every second hourly you increase? How you are going to tell? In a post-pilot feeding.
Every 4 hours, we have to see for any aspiration fatigue. Every 4 hours, we have to assess it.
You started this patient on post-pyloric feeding, and patient got admitted under gastroenterologist. So they came and suggested, okay, we want to initiate a probiotic for this patient. Which probiotic you are going to start, if at all?
Actually, probiotics have no role, sir. These probiotics are counterproductive.
Your answer for probiotic is no. Lots of data. So increased incidence of mesenteric ischemia when they given probiotics in severe acute pancreatitis. So no to probiotics. So you start at least a trickle or a tropic feed, and you go up on the feed every 4th hourly, increasing maybe 15 to 20 ml if it is a post pyloric. So how frequently you are going to aspirate rice tube to check whether it is tolerating feed or not? What is the recommendation?
Every 4 hourly we have to check, sir.
Every 4 hourly you will aspirate and will give? Is that the recommendation?
Current recommendation told no aspiration. If the patient is tolerating, not having any abdominal distension, we can continue with the feeds as well. But patient is having abdominal distension, which is causing some problem, then we can aspirate and see. Regarding post-pyloric feeds, if at all there is more than 40 ml over a period of 4 to 6 hours, then that is considered as increased residual volume. In GRV, it is more than 500 ml. We consider as an increase.
So normally gut is going to secrete around 80 to 100 ml per hour. So we are okay up to 400 ml in 4 hours. No consensus on how frequently to aspirate.
There no aspiration actually.
Yeah, no
aspiration. Recommend aspiration, and there's no point.
If they are
one more thing I want to ask you all. what is the blood sugar levels you have not mentioned? Is it important in pancreatitis?
Yes, ma'am.
So why is it yes means why?
Relative insulin deficiency can happen in the start of pancreatitis. So increased glucose, it also.
Is it important or not?
Yes, ma'am.
It's
also a part of Ranson's criteria.
Part of your this thing, because you have not mentioned in anywhere. That's the reason I have asked. Okay. Yes. Blood sugar is also very important. You have to find out how much is it. And if it is going high, then you have to take care of it. You can't allow it to be all the time going too high. So this is what you have to be watching out the patients. Then calcium you said is 5.5. Is that calcium?
Yes, ma'am.
Yeah. So what does that mean to you? Normally in pancreatitis, what happens? Calcium.
So it tends to come down because of secretion of the enzymes into the thing. The calcium tends to be on the lower side if there is increased amount of activity of the pancreatitis actively. That tells that still the patient can worsen. That's why it becomes a part of the prognostic marker as well in cancer.
So, is this 5.5 is good enough for you, or do you require to do anything for that? Or which calcium you are worried?
We're more worried about ionized calcium. We will tend to replace calcium if there is any symptomatic hypercalcemia is there, then we can think of it.
What is the symptom?
In tetany or any ECG changes having.
That is late, no? If you give it at that time.
Perioral numbness.
Okay.
Joystick style and
monitor and give if it is indicated. If you think, right? You want to say anything more?
So you are like commented on Ranson's, Glasgow, Imries, biceps and all. Is there any other way of prognosticating a patient with a pancreatitis? Any data available?
Apache 2 has actually a good prognosticate value. And other than that, CT severity index as well with Balthazar actually also tells about it.
Other than that, any studies they done on the markers like procalcitonin, C-reactive protein? Okay. So they also used them as a prognosticating marker. So there are data available. The duration of systemic inflammatory response syndrome, SIRS. See, they compared the persistence of the SIRS for 3 days versus that of the more than 5 days. Those patients who had a SIRS, this guy may be having a persistent SIRS itself, the persistent fever, tachycardia, tachypnea and all. So basically, that is also being used as one of the prognosticating marker. There is something called harmless acute pancreatitis score. Are you aware of that? What parameters it is included?
Absence of rebound tenderness. I don't remember completely.
So it is they included BUN and that of the serum creatinine value at the baseline and their trend and the sex of the patient. So have some sort of prognosticating value that is called harmless acute pancreatitis scoring system. So definitely even CRP, procalcitonin, they trended out to get an idea about the prognosis of pancreatitis. So we have taken care of this patient nicely, fluid resuscitation done, pain controlled, nutrition you have started, you have sent the culture. Okay. So after you started the nutrition, you got electrolytes and all, potassium is persistently low, you started having some sort of arrhythmia, again lactate are going up. What is your differential diagnosis at this level? So someone has commented in the chat bar. Basically, you told is having a loss of appetite with the background of ethanol. Okay, we worried about the refeeding syndrome also. And refeeding syndrome can occur both with the parenteral and that of the enteral nutrition, which present with hypokalemia, hypophosphatemia, okay, insulin resistance, again lactate withdrawal, Okay, so with the bad, we can have a worse scenario of the rhabdomyolysis, congestive heart failure, arrhythmia, and all. So it is having a high mortality. So this guy need definitely a thiamine supplementation. So you have to watch his phosphorus also when you start him on a feed. Very, very important.
Yes.
So you got the culture now. Next slide, please.
Next slide.
Yeah, read out, please.
Day 5, there was a new onset hypotension. The patient was started on R-adrenaline. We tried to have an IVC assessment, but the window was poor. We couldn't
can't
get an
do
IVC. Yeah. And respiratory-wise, the patient has an airway pattern, but tachypnea with bilateral crypts has started. Abdominal distension with diffuse tenderness and bowel sounds were sluggish. Urine output started dropping, and the lab values were like TLC has shot up to 17,000 with increase in urea and creatinine, and ABG showing metabolic acidosis, severe metabolic acidosis. And that time we started thinking of what can be the intra-abdominal pressure. We measured it and we found it to be 21 centimeters of water. Ultrasound again doesn't show any free fluid as well. So we took inserted an RT connected to suction drainage, and he hasn't passed through the last 2 days. So we tried to give an enema, and we have initiated on mechanical ventilation because of hypotension thing, and antibiotics we have escalated to imipenem at this point.
Means escalated means he was already on antibiotic.
No, he was not on any antibiotic. We started on imipenem.
So it is not escalated. So you started him on antibiotic.
Yes.
Why imipenem particularly?
Actually, carbapenems and fluoroquinolones and metronidazole having penetration to the necrotic tissue, sir. That's why we started on the imipenem.
Why not meropenem? He's having a creat of 2.2. So imipenem, one drawback as compared to meropenem is what?
There is a study compared between imipenem and meropenem, sir. With imipenem, hospital in-hospital days and complications were less with imipenem compared to meropenem, sir.
That was a very old study, but if you revise the recent meta-analysis and all, so really we don't get any data favoring imipenem particularly. So maybe nutshell carbapenem is okay in terms of penetration, and we have to take other consideration of his hemodynamics, your antibiogram, like whatever we do for other patients. So with a creatinine of 2.2, cilastatin is the concern. So may not be here. You don't have any neurological problem and all. But any carbapenem means like meropenem is also okay. Means now that data, old data which suggested decrease in need of surgical intervention and a bit of marginally improved means reduction in the mortality when you compare IMI versus meropenem. Meta-analysis or systematic review is not potentiating that data. Okay, so how much dosage you started him on imipenem?
We gave a loading 1 gram OD.
1 gram?
OD.
1 gram OD. How much duration? Why 1
these
gram?
are the things you have to understand when you tell the nurses. Exactly, that is what you have to tell. Otherwise, they'll give in 10 minutes. Okay? You have to understand these things, more important for you.
Why
OD? How to give?
Big.
Why not 8 hourly, a bit compromised dosage? Why you have given OD? No, imipenem is what? It is a time dependent, concentration dependent, or area?
It's a time dependent, which should be given over a period of infusion. 3 to 4 hours infusion should be given.
4 hours maybe it will lose its potency and all. Okay, 3 hours should be okay. But why not like you could have given 500 after giving a good bolus dosage? We can give 500 milligram Q8 hourly, no?
Yes.
Or maybe BD 500
Yes,
milligram.
Yes.
So if you really want to adjust the dosage according to creatinine clearance, if patient is not so sick, but in a sicker patient, don't go definitely by the creatinine clearance. We just give a proper dosage. So once stabilized in terms of your source control, hemodynamics has been improved. Okay, so then you can take a call on adjusting the dosage. So this patient, what is the culture on follow-up?
Culture showed no growth, sir, actually.
Mhm. So intra-abdominal pressure initially it was 21.
Yes, sir.
So are you going to tag this patient is having intra-abdominal compartment syndrome? What is the criteria for that?
So the pressure is more than 21 with the new onset organ dysfunction, as in kidneys has enzymes have got kidneys creatinine has been elevated. So can be called as an abdominal compartment syndrome.
What are the different types of abdominal compartment syndrome you are aware?
You are asking the grading, sir, or
Types.
primary and secondary? Primary, as in if the patient is having the source as in pancreatitis or intra-abdominal fluid collection is causing, call it as an primary. And secondary to
What is this?
increased fluid resuscitation, which is causing third space loss into the abdomen, which is causing compartment syndrome. We call it as secondary.
What is tertiary?
Not aware.
So if the abdominal compartment syndrome is recurrent, we call it as a tertiary. So pancreatitis guy is having a chance for both primary and secondary abdominal compartment. It may be a tummy origin or it is your external resuscitation which created the problem. Okay.
Yeah, before we go further on all this, because we went on mechanical ventilation, I felt it was a bit late in the day. So that's why it is dragged out. Because what is that we could have done on the third day when you have seen the patient? All the markers are high. Your C-reactive protein was high. All those things were high. Inflammation was quite severe. And with tachypnea and with a little bit of organ getting involved. So what anything else we could do at that time so that you can prevent all these other things? Is there any other thing which we can do for pancreatitis?
Pancreatitis is an infection or an inflammation? Madam is
Inflammation. Right?
So what
can you
thing
do?
you could have done
What to
prevent the
to
progression
prevent
of
all this? Okay, all this
cytokines?
storm of cytokines is there. What you can do? Is
What
there
is
anything? Is there anything? Work was done in our country.
What is ulinastatin?
You don't give him. Why you did not use in this particular patient? I would have used it, wouldn't have gone on mechanical ventilation. Right?
Yes.
Because there is a lot of literature, both retrospective, prospective. People have done it in pancreatitis in our own country. And they found to be it's quite useful. With the placebo randomized control trials were done. We have also done some.
How it acts, ulinastatin? What exactly it is? What
decreases the interleukin 6.
What is it? What is it? What is ulinastatin? You thought this old lady won't ask, then I'll ask everything.
What is ulinastatin?
What is ulinastatin?
Whether you use or not use, you should be aware of the ulinastatin.
Yeah.
Urinary trypsinogen inhibitor. So it is a serine protease inhibitor. Okay, so serine
protease inhibitor and a trypsin, inhibitor, urinary and trypsinogen inhibitor. So that is the thing. Usually given as IV, and it is in the beginning. It's better rather than on the 6th or 8th day. By about 2nd or 3rd day, when you see a patient, that is the time when all the markers are high. You can try. Most of the time, it does not require to. Another important thing is when the patient is having so much of difficulty and using up so much of oxygen in spite of all that, I would have intubated this patient a little earlier and come out, so that it is much better rather than to wait till hypotension occurs. Okay, that is, you have to go with the PO to FiO ratio. You can't say that I won't see that or the rate, but the oxygen saturation level is high, so I'm quite happy. That is not the criteria which we should relate to. So these are some of the things, and the calcium also was pretty low. Did you correct it? Did you give it?
Yes, ma'am.
Yeah.
Yes, ma'am.
So you should say those things, because at what level do you correct? Normal is what? Normal calcium level.
8 milligram. 8.8.
So now you had 5.5. Is it low or no?
Yes, ma'am.
So you give it, right?
Yes, ma'am.
So we don't have to wait for any carpopedal spasm or something, or a brady or something to occur. Okay? So these are the things which we have to be watching at the bedside. Then it will be much better. We act before we have a problem. Right?
If culture came as Pseudomonas positive, you've taken some sort of the blood culture initially, what is going to be your antibiotic option? You want to continue carbapenem, imipenem, or you want to change?
We can continue.
If it's sensitive, you want to continue.
Yes.
So you want to add any add-on antibiotic, or you're happy with the monotherapy?
What is the best antibiotic? Intra-abdominal sepsis with all these sort of organisms. Which one works better?
You want to add tigecycline for this patient?
Pseudomonas, no activity.
Yeah, so you have to remember, organism is very important. Even though we have a tigecycline as an option, Pseudomonas will not get covered by the tigecycline. So this guy worsened with his intra-abdominal compartment syndrome. So difficulty in ventilating, urine output is not improving. Okay, so he's not tolerating the feed at all. His peak airway pressures are increasing. His compliance is also worsening. So how you want to further proceed in this patient?
So we
consider intervention at this level? It
So
is
we have completely sedated and paralyzed this patient to decrease the intra-abdominal pressure as well, and we have given enemas and kept RT aspiration so that it again acts to decrease the intra-abdominal pressure. And as well, over the course of time, he actually improved.
No, I am giving a scenario if not improved. So how you are going to approach?
Even
So,
after conservative management, the
you want to intervene this patient, means some sort of need intervention. So at what time is the best time?
After 2 weeks.
What is pseudocyst of pancreas? What is walled of pancreas? How you are going to have a differentiation?
When we do a CT, if we have an homogeneous collection with thickened wall, which happens actually over after 3 to 4 weeks, if it is homogeneous, it will be a pseudocyst of pancreas, and there is heterogeneous with the liquefied material which is seen inside the collection with the thickened wall. Again, we call it as a wall of necrosis.
So ideally, recommendation is at least not before the 3 weeks. Okay, so it is definitely not before the 3 weeks. So after that only you are going to intervene. So at what size of pseudocyst you are going to intervene?
There is no as such recommendation as such size and extent of the pseudocyst. If there is any mechanical obstruction causing, or if there is like increase in abdominal pressure not amenable with the conservative management, again we can go ahead for physical intervention.
So it is a symptom which is very important than the size. Like there is no question of rule of 6 and all this. That is gone. What modality of the intervention? Suppose if the surgeon is going to discuss with you, which you are going to suggest as a best option?
Minimal invasive procedures were better compared with invasive procedures, open abdominal procedures. Minimal invasive procedures such as endoscopic guided drainage or percutaneous drainage were better compared with open methods, open laparotomy.
So what are the long-term sequelae of pancreatitis?
You can end up in diabetes, persistent pseudocyst can be there, and it can go into recurrent pancreatitis, chronic pancreatitis, malabsorption.
Pain. They'll go into chronic pain.
Chronic pain, and in situations they may land into may develop malignancy.
Malabsorption is one concern, diabetes, so acute and chronic, recurrent pain and all those things. Okay. So is there any other acute complications of pancreatitis you are going to expect other than the abdominal compartment syndrome? So secondary infection, infected necrosis and all those things. What other acute complications you can have?
Gastric outlet obstructions.
That is bit of subacute, may not be an acute kind of.
ARTS, acute renal failure, sepsis,
SIRS and ARDS.
Other than that, so many pancreatitis
thrombosis.
patients, yeah, so mesenteric vein thrombosis, splenic vein thrombosis, portal vein thrombosis. This is one of the worrisome complication which is going to occupy around 15 to 20% of the patient. So you need to have that in mind when you done some sort of the like imaging modality to get an idea is there any thrombus anywhere. So because they need a definitive therapeutic anticoagulation for that. That's also very important. Suppose this patient is posted for 3 weeks of some sort of intervention, minimally invasive intervention. So came back, difficulty in weaning, you attempted not tolerating the feed. So when you want to consider tracheostomy for this patient?
There is as such no difference between early and late tracheostomy. And
this patient wait for
abdominal pressure is actually the cause which is making us not able to wean most probably. So we should concentrate more on that rather than pushing the patient for an early tracheostomy.
Even though any patient who land up with such a like a bad outcome going up to the need of intervention and all, so you have to expect lots of in and around ICU, in and around like areas and all. Like if difficulty in weaning, you can take a call on bit of early tracheostomy to wean and all, because by that time all your nosocomial bugs will be bothering, is acute kidney injury, so all these complications will be there. So then you can take a call on bit early tracheostomy, wean, optimize the nutrition. When you want to give TPN for a pancreatitis patient?
What did you say?
TPN for a pancreatitis
TPN.
patient.
Okay.
Not able to achieve the goal after some 3 days, then we can start TPN with some amount of enteral nutrition as well.
You want to wait for 3 days for all the patients?
7 to 8 days, if you cannot, then you have to not TPN, at least partially with some nutrition.
Any of the trials you are aware, TPN versus enteral nutrition? What is EAT ICU trial? EDEN trial?
Not aware.
One thing I just want to tell you here, see, you are thoroughly prepared for pancreatitis, no doubt. If you start deviating, if I just go to hemodynamic monitoring on pancreatitis, all dynamic indices, this limitation, this, that and all, so it will take another 1.5 to 2 hours and all. But exam may not be a smooth kind of this one. So don't expect, okay, you'll get a straightforward only causes of pancreatitis.
You can ask for anything.
Yeah, so because
you can get stuck with pH and PCO2. Okay, there. So it is important that when you are present in such a way that questions will not be asked in the middle. That is the thing. You have to be thorough in presentation.
What is the role of immunonutrition in pancreatitis? What is immunonutrition?
Giving argin and insulin.
What is exactly the immunonutrition means? Pharmaconutrition or immunonutrition, what exactly it means? We have any role in pancreatitis?
No, is it a role is there in immunonutrition?
There is no role in pancreatitis as such.
Because you are not know about it, to say whatever. If they are saying something, then you can listen. Because hardly we are giving now.
So no role.
No role.
So anything which we use beyond their caloric value, we call it as pharmaconutrition or immunonutrition, but definitely no role per se other than a bit on micronutrients, including all this thiamine and electrolyte replacement. That is more than enough. No need of arginine, glutamine, or omega-3 fatty acids.
They were not shown to be of any benefit. On the contrary, they were having some ill effects which were happening. So there's no need for us to give as long as we can take care of the patient.
Any of the trials you are aware of on immunonutrition, which put full stop to glutamine?
No, sir.
No, sir.
So read up those things. Somebody will ask you, okay, why it went up, arginine and glutamine. Totally
this is bad because I'm just trying to deviate. We go smoothly. redox trial, you should be aware whether you are presenting a pancreatitis or you are presenting a head injury. Okay, so this is one recent trial which we got on IV glutamine versus that of the placebo onda. It showed a bit increase in mortality, those who have renal dysfunction and you use glutamine as an pharmaconutrition.
But don't you think they have given too higher dose?
Yeah. They were already.
So how can you always say that it is because of this?
Yeah.
When you give such high doses, they cannot be excreted. So is it the correct trial at all? So there are lots of things. If you tell them that it is not okay, not given, that's enough.
Any doubts you guys have on pancreatitis?
Or anything you want to tell us? It's nice to know from the youngsters something which you have seen, anything which was very useful for you during pancreatitis. Why some patients is a younger patient, you was a little older patient, you would have had.
When you want to do ERCP in pancreatitis patient?
When we suspect cholangitis, raised bilirubin values, we have to do ERCP within 72 hours of admission.
When you want to do cholecystectomy?
In case of mild disease, within the initial admission only, we can do cholecystectomy, sir. In case of severe, we have to wait for after stabilization.
When there is an obstruction, if there is an obstruction, then you have to do, right?
Yes.
If the stone is getting obstructed, suppose if the stone drops into, then it gets obstructed, then all the more reason you have to relieve it. That time, yes. Right? Cholecystectomy, how many patients of pancreatitis get a cholecystectomy done? How many have you seen? Seen any?
In your practice, you have seen any of the patients immediately posted for cholecystectomy?
No, ma'am.
No
one.
Because by the time a patient with a pancreatitis, they reach tertiary quaternary care center, no, they are definitely having a severe necrotizing pancreatitis. So on the floor cholecystectomy, it's not a good idea. So it is after maybe a couple of weeks, interval cholecystectomy, they can get done. Anything other than that? I think we covered everything. Yes, madam?
Yeah, I think so. Mostly, so you have to. Now, how do you assess this IAP? How are you doing it at bedside?
We connect a transducer to the urinary catheter actually. And first we place the patient in supine position and we keep the transducer at the mid-axillary line just above the iliac crest. And we empty the bladder and then we give 25 ml of normal saline into the bladder, close it, wait for 30 to 60 seconds and then measure the pressure at the end of expiration.
So how many times in a day you do that, or
if the pressure is high, we tend to measure every 4th hour limit.
That's okay, because that is what you have to know, and you have to tell the sister how to do it and correct. At least I'm glad you told all that method. That means you have done it at bedside. So that is important for you all. How you keep the transducer, how you connect it, which side, which of the thing is connected, and how much, the amount of this thing, the balloon which is blown in the thing. All those things, they do matter. So people have to be very clear in what they are doing at bedside and teach the nurses. Then it is easy for you to get that on a regular basis.
So I think 2-3 questions they are mentioning. Patient had a sudden cardiac arrest, young ethanol pancreatitis. I think someone answered. So dyselectrolemia. So again, we need to reconsider refilling syndrome here. Thrombotic events, because they are very badly dehydrated. Okay, so they can have all sort of thrombotic activities with the endothelial breach and all. Like that of splenic vein thrombosis, they are prone to have the thromboembolism. And dyselectrolemia, we need to get
potassium and calcium, these are the two things you have to be watching very carefully in these patients.
Someone is asking,
and even phosphate levels, magnesium levels, sometimes prolongation of the QTC. These are all the things which you can see in a pancreatitis patient. So one has to be, now and then I think it's also good to take an ECG, to just seeing the thing. But at least in the first 2-3 days till you correct them, one at least will give you a better idea.
So cytosarb role, so definitely you have to individualize, see, because problem is we can't have any sort of objective criteria. Okay, so after this WBC count will go for cytosarb, after this temperature or after this respiratory rate, we go for the cytosarb and all. See, somewhere we are trying to modulate this cytokine storm. We can take a call on ulnostatin than going for a costly affair with the cytosarb and all. But there are case reports, case series, they use it cytosarb to prevent that surge of the cytokine in pancreatitis patient also.
It's not really great achievement with only cytosarb to reduce the inflammatory markers. But I think better, as you said, and I did some work with ulnostatin and I found it to be pretty useful in the earlier stages. After 7 days, it's useless. Even if it is cytosarb late, it is not. Whatever you are doing, it has to be in the beginning, so that you can reduce the inflammation. The base is that you reduce the inflammation. First pain, reduce the inflammation. Pain also is causing more inflammation, so you have to do that.
So triglyceride, role of plasmapheresis, again case reports are there. So very high triglyceride, more than 1200, 1500. So usually we give like insulin infusion for triglyceride as immediate therapy that you can try. So if it is refractory, we also use it in one young chap who had a hypertriglyceridemia. We considered for therapeutic plasma exchange. So he came out. So, but anecdotal case reports are there on that plasma exchange. Hemodynamic monitoring. So definitely when you're stuck with some sort of like ongoing hypoperfusion with an expected way of resuscitation, like patient is bulky, leaky capillaries, go for a dynamic indices.
Dynamic indices.
Yeah, so all your
No doubt.
IVC don't tell in the exam at all. In a patient with tummy with
don't even go there. CVC or IVC.
So again,
with the dynamic parameters are always better if you are not able to get them.
And again, be careful on commenting a passive leg rise test in a pancreatitis.
Not in this.
Because abdominal
no passive leg rise in this.
So only
the dynamic parameters are better with a stroke volume.
So that also having a limitation because of abdominal compartment syndrome and all. So nutrition, as we told, around 25 kilocalories per kg per day, proteins of around 1.5 to 1.8 kilogram per kg per day. See, basically, you need to understand, don't jump on restricting the protein. So even though they have a bit high creatinine, okay, it is okay to go ahead and give. If they are definitely on dialysis, on the day of dialysis, you can give an extra protein on that day because hemodialysis is going to remove the proteins. Okay, off the day of SLED or off the dialysis, you can give at least 1.2 to 1.5 milligram per kg per day of the proteins and all. Don't restrict the protein. Even if you compromise the calorie, it's fine in the initial week, but they really need a protein for their high catabolism, which is going to be losing all the lean body tissue and all. So fluid management in AK and dialysis, definitely you need indices, means some sort of dynamic indices at each moment. So even though you have a limitation for PLR and all, if you have all the gadgets available, you take a call on getting some idea with the like extravascular lung water index, okay, global end diastolic volume. If you have a volume view and all, don't go by any of the single parameter. They are already leaky, okay, so their extravascular lung water index is going to be more than 7 and all. So because they are having an ARDS lung and all, but if they are still volume depleted with a low GBV, you can still take a call on giving some more additional fluid and all. So just by one marker or one indices of the hemodynamic.
Patient has to be seen in all directions. That is what. Prevent rather than treat. Yeah, so early interventions better than late intervention. Then ringer lactate. Do you want to use ringer lactate? Lactate is high. This is another question simply they ask you. Okay. What do you say? Doctor?
We can use, ma'am. Regulators can be used. It's no contract.
Why? Lactate is high, no?
Lactate is high just because of the decreased population as well. So when we give the fluid resuscitation, lactate will come down, and it's only minimal amount of lactate which is present in the RL as well.
So this lactate, what you are giving is converted to acetate. So it will not cause acidosis, right? If provided your liver is okay. If the liver is not okay, don't give. If the liver is okay, so that's why I am just saying these are how we ask the question sometimes to mislead you also. But you have to be very clear in your mind. This lactate is not going to go there and cause lactatemia. It will only be in there. So usually it's converted to acetate. But if the liver is not working, then don't use. That is what you have to use. Okay. I think we have covered most of the things.
Yeah,
Anybody
I'll
wants
take
to...
a couple of questions, madam. I think they are putting. Just I'll read out the question and I'll answer. Role of neostigmine for persistent ileus. See, if you are diagnosing it to be Ogilev syndrome with a pseudo obstruction and all, you can first try to correct all the underlying electrolytes. So then you can try to use the neostigmine and all. If it is an intestinal pseudo obstruction, fluid volume resuscitation trial. See, it is not a named trial. What I mentioned, 3 to 5 ml versus 10 ml. So it was published, I think, around more than 6-7 years back, which clearly suggests no need of 10 ml per kg in the initial 24 hours of fluid resuscitation. Role of expiratory laparotomy in pancreatic necrosis. See, basically, open necrosectomy is going to have a very high mortality. So initially, we tried with the phased manner of necrosectomy and all. Open and keep it method also very high mortality and very high chance of pancreatico-enteric fistula, pancreatico-percutaneous fistulas and all. So we have suffered in many patients to treat these kind of fistulas. When one young software engineer, within like unknown cause of pancreatitis, he had a very bad fistula and all, like with a post-abdominal open necrosectomy and all.
If I remember in the early years, I mean, now it is different. So they used to open up for every pancreatitis. Most of them used to die. So that is how it has come to saying that no surgery, up to 3 weeks, no, don't touch for anything. So that is how it has come. Earlier, it was more surgery. It was less medical intervention, because that time critical care also was not properly developed. I'm talking about 80s. Okay. So every patient who used to come with pancreatitis used to go under surgery. There was no endoscopy and all that in those days. So there was a lot of mortality. And if the pancreatitis patient developed ARDS, the mortality used to be 85 to 90% in those days. So that is what I'm saying, that there is so much change. There are so many drugs, so much understanding, and so many people who can really come together and work. And pancreatitis, you can't treat only one symptom or whatever. It is a sort of a syndrome. So you have to treat almost everything, keeping everything at your fingertips every day, day-to-day basis, morning, evening. That is how it will work to come out better.
Albumin, see, basically you keep the same knowledge on albumin for whatever the resuscitation that applies to pancreatitis also. Nothing special. So if you want to use after a bit of good volume of balanced crystallites and all, maybe 4 or 5% albumin you can take it all. But nobody knows whether it stays intravascular or it will go to interstitium. So it is individualized kind of this one. Normal saline definitely maybe up to around 800 ml, 1.5 liter, it's okay. Don't continue 150 ml per hour of the normal saline 24/7 and all. So we learned a lot on normal saline in the recent trials also. One major trial is that is the SMART trial. So other than TD trial and all. But definitely, if someone asks normal saline, we totally ban, answer is no. Up to 1.5 liter, it's fine. Okay. Problem is if you keep on continuously using 150, 200 ml per hour with a recurrent bolus of the normal saline, so then we have a problem.
It's always easy to mix normal saline, ringer lactate. Both you can use.
Yeah.
Up to about a liter or 2 liters. There is no problem at all.
Yeah.
Point is when you start using the whole normal saline, hamburger's phenomena, which is normal. The chloride will go inside and bicarb will come out. When you know about it, there's no point in using that sort of a thing when it is not physiologically okay. I don't know, sometimes we unnecessarily do these trials, but I'm just saying the normal physiology is that. So what is the point in going on loading anybody with normal saline? You will only increase sodium, again it will draw water, and you will increase chloride, you are putting more, and bicarb is going, so you will have acidosis. So you have more fluid inside and acidosis. So what is that you are gaining? Nothing. So always you can combine these finger lactate, normal saline, or a plasmalite, whatever you have, in a nice way and use them.
Okay, last question, I think, on Panther trial. It is not Panther, it is a Panther, P-A-N-T-R, Panther trial. So that we discussed. It is a stepwise necrosectomy versus an aggressive open necrosectomy, which showed the trial, I think, published at 2007, 2008, or maybe before that. So which clearly suggested aggressive necrosectomy is bad. That is Panther trial. I think, Shashidhar, we are okay to conclude. Madam, we'll conclude now.
Yeah.
Yeah.
I think so.
Thank you, madam. Thank you, Dr. Harish, for your valuable time and knowledge sharing to all the students all over the India. Thanks, Dr. Vignesh and Dr. Uday for bringing a good case. I will conclude the session.
Thank you.
Thank you, sir.
Thank you, ma'am.
Thank you, sir. Thank you, sir.